Good afternoon, everybody. I'm Karen DeSalvo, and I'm a faculty member in the departments of medicine and in population health. And it's really a great joy for us to be able to host a dear friend, mentor of mine, Drew Altman. Drew is the CEO and president of the Kaiser Family Foundation, and hopefully you all are familiar with that organization. It's an entity is storied and done a lot of great work, including in HIV around the world. But Drew has seen that under his leadership, it has become a really quintessential nonpartisan voice for the pulse of America, but also helping to shape policy in the country in a very evidence-based way. And as part of that, started the Kaiser Health News, which is an arm that allows more of a lay communications platform, in addition to the way that they communicate with policymakers. You hopefully have had a chance to see Drew's biography. He's very experienced in public service and in the private sector. In fact, we were just talking about his 4 years in New Jersey as the Commissioner of Human Services. He's worked in the philanthropic world and senior leadership. But what I wanted to say about Drew is more personal. I met him now a little more than 20 years ago when I was a junior baby faculty at Tulane in New Orleans, and Drew and the Kaiser Family Foundation began to recognize that they could help bring voice to the people of New Orleans and the work that needed to happen there, and that was long before Katrina happened. So when Katrina happened, they were poised and ready to make sure they could do a set of serial surveys from the ground to let people know what was actually happening to the community there, and were instrumental in helping us get connected to the right leaders and thinkers and decision makers across the country so that we could take that kind of information, the voice of people, and turn that into policy that would change the lives of people every day. He's also a kind person and a wonderful mentor, and it's just a delight to welcome you to Austin. Drew, I'm going to turn it over to you.
And to you for coming, thank you. Every time I get called a mentor, I feel very honored and very old, but thank you for that. And when I get that kind of introduction, I always like to tell the story of a letter I got from my then 99-year-old grandmother, whose name happened to be Dora Auerbach, the day I got my PhD in political science at MIT. It's true. And all the letter said in her scrawl was, her palsied scrawl was, "Dear Drew, about that degree. So what are you going to do, open a political science store?" She would have given a very different and introduction than Karen's introduction. I also need to warn you that one of the times I was in government, I was described in it was the New York Times, as a nice guy trapped in a deadly serious face. So I'm happy to be here because DEL stands for everything that I believe in. I am truly happy to be here. It's just that evidently there's no way you would ever know that. I also want to say a word about Dr. DeSalvo, who is the person who brought me here today. But not the usual things about Karen. I first met Karen, as she was saying, after Katrina. We'd just actually done a survey of the evacuees in the Houston shelters with the Washington Post, and we went to New Orleans to try and figure out what we could do next. And Karen took us under her wing, meaning she took complete and utter control of us. There was no wiggle room at all. So we started by meeting for breakfast at some place, and this was not too long after Katrina, and I think there was only one place open. And so all of us vegetarians from California marched into this place, and the only thing they were serving was something called grits and debris. So in my life, lived a while now. I've been shot at, I briefed presidents, I had to learn recently the rumba, to do the father-daughter dance with my daughter at her wedding. Nothing in my life scared me more than those goddamn grits and debris. And it now has been a wonderful, decades-long mutual admiration society. And since you're wondering, I ate the grits, but I didn't go near the debris. I still don't know what the debris was. For those of you who don't know me, I'm an ex-academic. I'm an ex-political scientist from MIT who's abandoned academia. My career has been, as you heard, in federal and state government, a couple of big East Coast foundations. Before coming to California to start the current day, we now call it KFF, when a previous organization called the Henry J. Kaiser Family Foundation had some challenges and was dissolved. It was a first government job in the Carter administration. I don't know how many of you even remember the Carter administration, but it was in the Carter administration that changed my life. It made it about public service, which is what I like to think I do and what I've always done and what we do at KFF. I look back with special fondness, actually, at that job as Commissioner of Human Services in the state of New Jersey, all the things we accomplished there. I'm a very big fan, as we were discussing, of state government. When the circumstances are right, it's a place where policy and impact really do come together for me in a very meaningful way, although I have to admit I never tried it in Texas. I don't know that much about doing it in Texas, but that does allow me to tell you my favorite story about my New Jersey state government experience, which happened on the very first day I had the job. I was too young, and so I went to Trenton. It was the first time I'd been in Trenton. There's no reason to go to Trenton if you don't have to go there. So I wandered around Trenton, and I couldn't find the job. And there was a building. I wasn't sure if it was the right place. There was a guard. And I said, I'm the new commissioner. And he's like, sure you are. And finally he said, well, kid, he called me kid, it's in there. So I went in and talked my way up to the 11th floor. There was no sign on the front of the building. And I had my big idea. So I said hello to everyone in, I thought, an appropriate way. And then I said, folks, we're the largest organization in the state of New Jersey. We were at the time. We're bigger than any of the drug companies. And I know we're proud of what we do. Let's have a sign in front of the building. There will be a sign in front of this building. Well, 9 months later, after the job was stopped because first the wrong procurement rules were used, and then a second time because the wrong union worked on the job, and then a third time by a wonderful letter from the State Department of Treasury, which could only occur in government, which said, this job should not go forward because it is too small to do. By then, there were newspaper stories, will Commissioner Altman get his sign? And it was my birthday, and my chief of staff came in and said, you need to come down to the front of the building. So I sort of knew what was going on. I came down, there must have been 1,000 people there, the press corps was there, and there were huge sheets draped in front of the building, and they peeled it back, and there it was, the New Jersey State Department of Hunan Services. They spelled it wrong. Which is my metaphor for a lot of stuff. It might be that what you do in government is unbelievably important, but it's hard to get stuff done. And what you do in you can get stuff done in the private sector, but I won't finish the point because I don't really believe that, but it might be that. Now, I want to tell you a little bit about us as context for the talk that I want to do today, because I kind of assume that you see some of our stuff and a lot of our stuff, but there's no reason that you should know. So I'll start with this, which will lead to another story that I just have to tell you. But I established what we now call KFF. It was way back in 1991. And the reason I want to tell you that is that I did it with a founding board that included one of, if not the most famous citizens of Austin, Texas, the great Barbara Jordan. And Barbara became one of my closest friends in life and was a member of our founding board. And so, can I just tell you my favorite Barbara Jordan story? Because as far as I know, it's not public. It's not a story that's kind of in the records, and I just think it's great. Our one of our biggest efforts at that time was a big effort in South Africa to prepare the way for democracy there and the transformation working with Mandela and the ANC. And so before apartheid fell, I went to South Africa with Barbara in her wheelchair and Joe Califano, who some of you may know of, who was then secretary of what was then HEW. This is how long ago that was. For some reason on the trip, Barbara decided that she wanted to meet with the top general of the apartheid South African army to see how he thought about stuff. And so we arranged the meeting. We met with this guy in a little hotel outside of Cape Town, just me, Barbara, and Joe Califano. You all know of Barbara as the great orator, but to choose a word, when she got pissed off, she would become stonily silent, so she didn't say a word. And this guy just was there talking to us. About 10 minutes into the meeting, he stood up with all of his epaulets and medals. And they actually had nuclear weapons then in South Africa, which the Israelis helped them develop. And he said, "I want you people to know that I don't like what you're doing in my country, and I'm prepared to give my life to stop the blacks from taking over this country." Without a half a second going by, Barbara looked up from her wheelchair and said, "Well, sir, we may just need to take you up on that kind offer." And she wheeled around in her wheelchair, clipping his chair, wheeled out of the room, and he fled the room in utter panic, and that was the end of the meeting. I just think it's a great Barbara Jordan story. And I have many others, but I'm not going to spend my whole talk on Barbara Jordan stories. I could. The basic idea was to set up an organization, an information organization, as health was becoming a bigger issue. It could be a trusted source of information on these national health issues, but there was kind of a secret plan, and it was that through information and with no delusions of grandeur, we could try and be a counterweight to the money in politics and health, using data as a voice for people, which Karen kind of said, and I appreciate that she said it. And we do it in three main ways at Kaiser. We do lots of policy analysis and research. We do lots of polling and survey research, which is mostly what I'm going to talk about today. And we do it also through our journalism, which is our principal vehicle for broadly reaching the American people. And it's actually the case that Kaiser Health News is now the largest health newsroom in the country. And I can talk about it more later if you're interested in it. We are California-based with a substantial DC presence. We did not want to become another Beltway organization. And because there's sometimes confusion about this, and I don't want to disappoint you about grants, I know we're called a foundation, but we're actually not a foundation. The best way to think about us is as an endowed nonprofit organization. Technically, we're something called a public charity. And so about 75% of our operations are supported by our endowment, and the rest actually comes from foundations. So please don't ask me for a grant. We actually ask other people for grants. And finally, and I guess importantly, we have absolutely no connection of any kind to them. Now, who are them? You know who they are. The big guys in Oakland, to Kaiser Permanente. Because that's a common confusion, except for the occasional letters I get which say things like, "How in the world could you use my precious premium dollars for that stupid study of the ACA?" But no connection at all. I'm going to mostly talk about results from surveys and polls today, but not entirely. So I want to spend just one more minute on why we do that. We thought in the beginning, when we set up the organization, there was a need for an independent source of polling and survey research in health that wasn't brought to you by media organizations that follow the hot political debates or by advocacy groups, though I certainly have no issues with advocacy groups. We do this to give the public a voice in the system, especially groups that don't have them. So we do polls of the people in Puerto Rico about how they're feeling about the recovery. We did 4 in New Orleans over the years after Katrina. The South African people, our soldiers who've been in combat in Iraq and Afghanistan, college students about sexual assault, minorities, seniors, people in Houston. after Harvey, and on and on and on. We do not believe, of course, that we or the country should simply do what people say in the polls. We believe this is a way to identify where our challenges are, and especially where information needs lie. So this, for us, is importantly a tool for journalism and for our news service as well. And this is something that I really preach. I always preach experience trumps opinion, by which I mean we focus a lot in our polls on what's actually happening to people, not I like the Trump plan, I don't like the Trump plan, in the healthcare system. And I will be showing some of that to you today. And we poll mostly ourselves, but we also specialize in polling with major news organizations. Our biggest and longest standing partners are the Washington Post, with whom we've done 34 major in-depth polling projects, but also The Economist, the New York Times, the LA Times, the Cook Political Report. And in those surveys, we go far beyond health and look at all kinds of issues. And this has kind of worked out for us. So we're kind of regarded as, credible and reasonably good at this. So today, with that as background, I picked a bunch of non-controversial issues that I thought I would talk to you about. They are the ACA, Medicare-for-all, Medicaid, all these briefly, and my own pet subject that I really mostly want to talk about today, which I call the silent crisis that I see in affordability for people who are sick in our country and for low-wage workers in our country. And then I'll close with a little bit on where healthcare stands in the election, because I assume we're all thinking to one degree or another about the election. And so here we go. Here's a slide that represents a lot of data. If you have been following the debate about the ACA, it has been all fireworks, lots of cliffhangers. You followed those cliffhangers. So you might think that public opinion on the ACA is volatile, kind of like the stock market. It's up and down, except, you know what? We have been polling about this at least every month since 2010, and it has not been. It has been incredibly, remarkably stable, with an uptick recently in support for the ACA since John McCain's dramatic thumbs down, which I somehow tried to cram into the slide. I don't know if I did it successfully. But, and a more important point and a theme for today, this stability is not randomly distributed. It camouflages, it covers. The most striking, I would say almost virulent, partisan division on this issue, and not every issue we work on in health, but most of the issues I work on in health, and it is profoundly important. And so when we look at it that way, we see this. And you could not see a more striking partisan divide sustained throughout the debate about the ACA, but this isn't just about the ACA. So it's not just that there's a partisan divide on the ACA, it's worse. It's that our issue has actually become the poster child of partisan division in the country. You might think we're debating the ACA. When we debate the ACA, that seems logical. We're actually not. We are, through the debate about the ACA, debating larger divisions and political cleavages, to use a political science term, in the country. If there is a lesson there are many lessons, but one lesson from the debate so far about the ACA, I think, is obviously the limitations of passing and implementing any kind of big health reform program without bipartisan support, even if there was no choice but to do it that way. And certainly there's a strong argument that there was no choice. I want to try and drive this point home a little bit more for you, because the depths of it are pretty extreme. We see the partisan divide on the ACA, also on other stuff, in almost every question you ask. Here you see it on a very basic question: how people think the ACA has affected them and their families. Obviously, it doesn't affect everyone, but they think it does. And so you can see that 10% of Democrats think that it's negatively affect them or hurt them. 52% of Republicans think that. Here's another example of that. People actually think they're having partisan experiences in the ACA marketplaces. The same people. We've done the regression analysis with very similar or almost identical incomes. And so 75% of Democrats say, I'm having a good experience, and 57% of Republicans. These are the same people. And finally, just to make the point in the extreme, even though these are old data, you would think that you wouldn't see that with some groups. You certainly wouldn't see it with physicians in America, because physicians are evidence-based. So their views on the ACA would be more broadly distributed. Except there's really only one thing that explains the views of physicians on the ACA. I can't, you see what it says. And it's pretty profound. I am convinced at this point that we could literally ask, will the ACA take us to Mars, or will it solve the climate change problem? And we would get this result. Except the head of my polling program, who's quite distinguished, will not let me ask those questions. Complicating this are the levels of public knowledge, which are so low about all of this. And they're low for reasons, the spin and the nature of the debate that we have. So, for example, the singular achievement of the ACA has been lowering the uninsured rate in the country. Just 4 in 10 Americans know that, and 3 in 10 think it's actually increased the number of uninsured in the country. Of course, you would see partisan differences about that. And while I could show you 30 slides on this, I just want to really show you one more, which is this. It's the worst one. Still, 6 in 10 Americans either think there are death panels in the ACA, or they're not sure about that. So you can see where the levels of information are about this. Sarah Palin was successful at one thing. This was the thing that she was successful about. I'm going to skip over the next 2 points just for time and make a different point. Still, despite all this, slowly, over time, as repeal and replace gave people a sense of what they had to lose, the ACA has persevered. It's like the Marines. What is that? Adapt, overcome, and persevere, I think. It's even prevailed, despite all these obstacles. And that is largely because the public has come to value so many of its provisions. And what's interesting about this particular finding is that the one that you think of, the one that played such a big role in the midterm elections, pre-existing conditions, isn't even remotely the most popular one. There are a number of others which are more popular, and you can see that in the slide. I don't need to read the slide to you. And it's even true for Republicans, and I'm not going to show you a slide on that. I write a little column in Axios every week, and I wrote about that if you want to check it out, rather than show you a slide. So I thought I would next take on a less controversial issue than the ACA, which is Medicare-for-all. We have seen over time, it's been called different things over time, only recently Medicare-for-all, a growing support in energy for the general idea. You might even think of it as a slogan, but the general idea of Medicare-for-all. But especially in the progressive Democratic base and among activists in the Democratic Party. We also see that what you call it really, really, really does matter. So Medicare-for-all is the most popular thing to call it. National health plan, pretty good. Single payer, do not call it socialized medicine. You all know there's no Medicare in Medicare-for-all. So Bernie knows this, but also the Republicans know that. And that's why they run around and call it socialized medicine. The language matters. We, of course, see the partisan division on this and the partisan split. So Democrats like it, and to Republicans, it's grits and debris. They don't like it. They're vegetarians on this issue. And as this debate gets going, we're seeing the two sides get increasingly dug in. So Democrats are liking it more, and Republicans are liking it less. It portends, I think, a little bit about where this debate is going. What we are seeing now is a debate about words, slogans, concepts, values, not a plan, not trade-offs. It's not yet a real debate. We sometimes try and simulate imperfectly, a little bit of what might happen in a real debate just by asking people, well, what would you think if you heard this, and what would you think if you heard that? And you can see here the huge swings that occur in public opinion when people hear the arguments. So what this means is that the debate that you're seeing now has really little to do with and little resemblance to what a real debate about actual legislation would look like, with ad campaigns and trade-offs, and that will depend a lot on who the messenger is, or the messengers, and how good they are. And again, information matters and misconceptions matter, so people have a sense they would pay more in taxes. I can't tell you if they know or don't know that they might save what they spend if their premiums go away at work. But you can also see some of the potentially significant misconceptions. Over half of the American people think, well, sure, I'd hold on to my employer-based health insurance. Under some plans, they might. Under the orthodox plans or Bernie's plan, they would not. And so we end with this, where we ask them about a variety of different ways to expand Medicare or other public programs. And it is not surprising that the ones that are most popular are the ones which are the most optional, voluntary, or incremental, and therefore least threatening. And so it's a hypothesis, which I wouldn't argue too strongly, because it depends on lots of things, including elections, that these might be the ideas that are left standing at the end of the day, if we ever get there sometime after 2020. This is my favorite program, so I do want to just spend a minute on Medicaid. In the political and provider world, Medicaid has historically been the program that everyone has some reason not to like. Conservatives don't like it because to them it's the Pac-Man of budgets, and it's an entitlement program. And liberals are defending it now, but historically they've always seen inequities between the states, and the program just never did enough and didn't go far enough. And you all know what providers don't like about the program. The rates are too low. So while almost no one was looking, despite all that, Medicaid has actually become as popular with people in the country as the sacrosanct programs, not quite, but almost, Medicare and Social Security. And here's why. It's because now 70% of the American people have a connection to the program. They, a family member, a close friend, are on the program. And as you can see in the slide, they have a favorable view of it, and it's important to them, and they don't want to cut it. And so it's a program that reaches now deeply into American society. And if they're in a state that hasn't expanded it, they want to expand it as well. Well, certainly not in Texas. That wouldn't be the case in Texas, except in one survey that we did with for the Episcopal Health Foundation, they do. They know it isn't expanded now. This is in a country that still thinks there are death panels in the ACA, and a solid majority, 64%, think that Medicaid should be expanded. And yes, of course, it's partisan. There's a partisan difference, but still. At the core of this Medicaid debate is really a fundamental difference between liberals and conservatives and Republicans and Democrats about how they view the Medicaid program. And so conservatives view it as a welfare program, and Democrats view it as an insurance program for low-income people. And it turns out it really, really matters, because sadly in our country, if you view something as a welfare program, you tend to want to cut it and spindle it and impose requirements for people to get it, and if you view it as an insurance program, you want to protect it, and you may want to expand it as well. And we see that difference. Think about it. No one ever proposed a work requirement for your Blue Cross or your Cigna coverage. We see that underlying difference behind everything that we do on Medicaid. And so when we ask about the future of the program, what should it be? And I'm not going to walk you through this complicated language that we spent, weeks trying to write. We push the limits of polling on policy, maybe beyond the limits at our organization. But basically, the question is, do you think there should be some kind of national guarantee and program for low-income people in the country? Or do you think we should give it to the states? And by the way, with some big cuts in funding, which in the actual proposals are about $1 trillion over 10 years. And you can see the difference here between Republicans and Democrats. And it is mostly because of this underlying difference. This is what I mostly want to talk to you about today, and then I'll end with the election. What I am seeing in our surveys now, I would describe as no less than a silent crisis in affordability for sick people, also lower wage workers. Silent, I mean, because we don't talk about it much or enough in my view, and it has little or nothing to do with the ACA. And it has to do with the fact and the ways in which insurance has been changing under the radar while we've been so focused on the ACA as a country. So I'll just start with this. With the significant percentages of Americans who are struggling to pay their medical bills, especially their deductibles, and you can see how it's up even just by these various measures in recent years. Deductibles on the far right here, that's 43%. This is not perception. It's not in people's heads. It's very real. I say that because of another survey we do every year of employers, where we see what's happening with deductibles, that's the yellow line, compared with what's happening with people's wages, that's the blue line. And that gap is, to me, the pain factor for people. Within the last year, deductibles rising 4 times faster than wages, but over a 10-year period, 8 times faster than wages. And that's what's really hurting people. So wages are starting to go up a little bit, and that will change it a little bit. And we see this, and this is actually amazing to me, that medical bills are such a big worry that people are more worried about these different kinds of medical bills, their surprise bills, their deductibles, their drug costs, than they are about the stuff that you would think people worry about the most. Paying the rent or the mortgage, food, paying for their utilities. And so what it means to me is our issue, healthcare, has become manifestly a pocketbook issue. You may have noticed in the slide that surprise bills was at the top of the list. That was kind of a surprise to me, because experts don't talk about that much when we talk about healthcare costs. And it's because a lot of people think they experience them. You can see over on the left, it's 4 and 10 over a 2-year period. And for people, it's not just for out-of-network care. There are a lot of bills that they think they figured out their insurance, surprising to them. It's also not just the big bills. It's the $200, the $400. So many Americans live week to week. This is why it matters to me. And what we hear about all the time from voters. These are the consequences. The large numbers of people who are having problems, who have done things like cut spending on household items, used up most of their savings, taken another job, borrowed money from friends or family. These are the things, I won't read you the whole list, that ripple through family budgets, ripple through families, can devastate families. We just focus on bankruptcies. It's a lot more than bankruptcies. And also, by the way, affect people's health and mental health. It has made me worry that for the entire time I've been in the field, we have misframed our issue as an issue of access to care. Now 90% of Americans have insurance, as an issue of access to care and not a pocketbook issue. I am concerned about that. 2 groups are hit the hardest by this. We have a big debate about affordability in the ACA marketplaces, and we should. Some of the plans are not affordable. But if you compare affordability in the marketplaces where people get subsidies to affordability for low-wage workers in the general employment-based system where 156 million Americans get coverage, It's really much worse in that second system. So people in the marketplaces spend 8.4% of their income on healthcare. That's a lot, but you can see the corresponding number in the other system. It's twice that, and that is not affordable. So I worry about that group, and this is the group, this is the silent crisis to me, and the group I really worry about. It's people who are sick. It's people who have major medical conditions, cancer, stroke, heart disease, diabetes, mental health. Over 60% of them report putting off care in some important way because of their costs, because of their affordability problems, and a similarly large number, not as big, but big, 39%, so almost 4 in 10 struggling with their bills. So that's not surprising, right? Sick people use more medical care, but it is exactly, to me, the opposite of how a functioning and compassionate healthcare system should work. It should take care of sick people most of all, not healthy people. And it is what is behind the power of healthcare as a political issue, because people who are healthy worry that they or someone in their family will get sick and will have this problem. That's why pre-existing conditions resonates as an issue. We've been trying to popularize this issue through something called Bill of the Month on KHN. And by the way, this is just a shameless plug. If you want to keep up with all of this stuff, just check out our podcast, which Julie Rovner does, our Washington correspondent, with all women health journalists, because Julie's line is, we'd have a man if we ever found one that was any good, which is really great, and you can check in on that. How am I doing in time? Okay, I'm okay. So I just want to talk for a second about the election, but not the midterms.
You're good. It's 5:40.
Okay, but I want to talk with people. No, let me just do a little on the election, and then I'll end up. As we look at the public's priorities, as we think about the election coming, one interesting thing that we see in the polling is that the way I would put it is that the candidates' priorities are speaking more to the base and the activists in the party and the contributors than the priorities right now of the voters and the American people, which are, guess what? Just what I've been showing you so far today. So you see in this slide what they are. Drug costs, pre-existing conditions, surprise bills. It's almost as if the candidates are speaking policy when people want help with their costs. And this we hear really in our focus groups. We just did a series of focus groups, which were really astonishing in that in them, not a single person had heard of Medicare-for-all, had heard of it. That was just really surprising. And they, of course, were focused on this other stuff that I'm telling you about. This is true across partisan lines, except that Republicans are still interested in clinging to repeal and replace. When we asked them about this Texas court case, they are more concerned that if it goes, I would say the wrong way, if it goes one way, they will lose protections for pre-existing conditions than they are that the whole ACA would be thrown out. That is because they're focused on these concrete and practical issues. And when we poll Democrats broadly, they're more focused on protecting the ACA than on Medicare-for-all. This just reflects the concern with these meat and potatoes, practical issues that people have. And it raises an interesting political question you can all watch, which is, when we get through the primaries, will whoever the Democratic candidate be able to pivot and focus more on these practical and pragmatic concerns? And some potential candidates are more pivotable than others. I don't imagine Bernie Sanders pivoting from Medicare-for-all, for example. And just one last thing on the election. So as we go through the election period, you will see you'll flip on CNN or whatever you do, and you'll see poll after poll, and it will say health is the top issue, and then we'll have the election, and it will say health was the top issue in the exit polls. And on TV, they will imply that health decided the election. That will not be true. because it's in the title of the slide. Issues are not the top factor in voting. There are always other factors, which they don't tell you when they show you just a list of issues, and they tell you that health, and they're obvious. And those issues are, they voted on the candidate. They do or they don't like President Trump. They vote their party. There are also state and local issues that affect the vote. So please keep that in mind, because you will see that. This election was decided by pre-existing conditions. The next one was decided by healthcare because the exit polls showed it was the top issue. That will not be true. What will be true is it was the top issue, and it played a significant role in the election, but not that it decided the election. So I want to end with this. I often wonder why we don't focus more on what I would call people's problems and perspectives in the healthcare discussion and the healthcare debate. So I'm going to end with this kind of big picture rumination about that I'm not at all confident about, but it's just a way of kind of illustrating this. And it's a Venn diagram, and it's this. And it is just that, our field is a series of only partially overlapping agendas and conversations. And this is one way of picturing it, that the policymakers and the politicians are not entirely, but mostly focused on the ACA and Medicare-for-all. The media follows the hot issues. We, as experts, leaders in healthcare institutions and the health professions, I don't use the word provider, sorry, I refuse to use it, are focused on delivery and payment reform and value, by which we mean many things. And I've already talked about what the public is focused on. We all have to do more to connect our issues to people. It's not we need to focus on other things. We need to connect what we are concerned about to the everyday concerns of people. And here's just another way of saying the same thing. If we think about healthcare costs, employers are focused on their premiums. In Washington and in the Congress, they're focused on federal spending for Medicare and Medicaid. Us experts are focused on the percentage of GDP that goes to health. We've talked about value for the healthcare dollar. And consumers aren't focused on any of that stuff. They're focused on putting food on the table and how healthcare affects that. So these are my takeaways from this, three takeaways. That the public is incredibly divided along partisan lines on most of these health policy issues, with some exceptions, because health is a symbol of the larger divisions in the country. And this partisan divide is toxic and is the enemy of progress, and we need to work harder at finding, and they're not pretty, bipartisan solutions to these problems. I do believe there is a big healthcare problem. I actually think it's the biggest healthcare problem right now we don't talk about enough. It's the affordability crisis facing people with major conditions. And I think what's missing most in healthcare right now is what I'll call a consumer agenda that approaches healthcare the way people experience it. And everyone, experts, journalists, and candidates can and should do more to focus on that. So, on behalf of the New Jersey Department of Hunan Services, thank you very much. I would love to have a few questions if you have some. Please tell me just who you are and sort of what you do.
Hi, my name is Kevin Bozick. I'm the chair of surgery and perioperative care. First of all, thanks to Karen for inviting you, and thanks for sharing that perspective. I'll just acknowledge that I'm a big fan of the work of your organization. We publish a value-based healthcare reading list every week, and we always have 2 or 3 articles on there every week, and they get a lot of retweets, and so we're obviously very invested in what you're doing. I asked you to put on your journalism hat for a second, and from where I sit, it seems like much of the polarity around the Affordable Care Act centers around health insurance, expansion of Medicaid, public subsidies of health exchange premiums, things like that. The part that my understanding has much more bipartisan support and is much more agreeable is the transition to value-based payment and delivery models that you put up in one of your circles there. That seems to be less polarizing and something that has gotten, at least over time, broad support from both sides of the aisle. It seems to get less play and coverage, and your framing comments at the end made me think maybe we're framing it as too much of an academic exercise rather than framing it as these are strategies to improve health outcomes and reduce the overall cost of care, which addresses all of those other issues. So I'm wondering why in your organization and others it gets less play than the insurance coverage issues, and why it's not resonating with the public is because we're not framing it the right way.
You sort of answered your own question. Effectively, I'm tempted to just say yes, right, but that's absolutely right. At KHN, we don't chase around a lot the kind of partisan and Washington disputes because others do that, and we try and focus. The hallmark of our organization is a focus on people. So we try and focus on what's happening to people out in the country, whether it's as a result of policy or the healthcare system. But in general, media organizations follow the hot legislative and political issues, and that's why they're not focused so much on that. It's also why they're not focused on the issue I'm trying to raise today of the problems affecting very sick people, the affordability crisis affecting sick people, because it's not a hot political issue. There's no legislation about it right now. There's no partisan disagreement about it. So, I think it is a challenge for journalism. That is an area, value-based care, and there are others. We've talked about some on the side today, opioids, mental health. There are some others where there are opportunities for bipartisan agreement, makes those issues different. Even so, the environment right now is so toxic, it's, there may be more chance of action in some states than for now in Washington. The possibilities right now in the Congress are on drugs and on surprise bills. I wouldn't bet on legislation actually being passed in both chambers and being signed by Trump in either case, but the possibilities are in those two areas. But yeah, you're right. I mean, you're absolutely right. And the journalists know that, but it's not where you get the clicks, and it's not where you get the views, and it's actually, I don't mean to go on here, why when I set up KHN, intentionally set it up, one, as a nonprofit model, and two, not as a destination website, but rather based on what I call distribution model. So the stories we write every day are distributed for free through all the mainstream news organizations in the country, so we don't have to worry about what gets clicks and views, which I regard as pernicious as commercial incentives.
Great, we have another question in the back.
Yeah, thank you. Thank you for your talk. My name is Kwang. I'm with Torch Rural Hospital Association. We represent all of the rural hospitals here in Texas. And just as you were talking about the stark political divide between Republican and Democrats, when we look at the political maps, we also see a stark difference between rural versus urban.
Yeah.
And some might say in the last couple political cycle, the elections, that rural carries the bacon for some of the top political positions out there. And yet we see a diminishing representation for rural at the political theater. Do you have any research or any of your work show that there might be some action or some policy or some resources directed to support rural, given that rural is sort of the thing that carry the politics of the day?
There are some interesting models in states. We're trying to develop new models to address the challenges facing rural hospitals in particular, but politically, I think Democrats have been remiss in not placing a greater emphasis on rural health and rural hospitals, because there is another way of looking at the political divide is as a urban-rural divide with suburbs up for grabs. And so a way to cross that chasm politically is to find issues like rural health that can help you do it. I'm not sure if that's where you were going, but it might be. And so, if I were involved in politics and formulating a health agenda, it would have a heavy dose of rural health.
Hi, my name is Eliza Norwood. I'm a primary care physician here at Community Care, and I teach at the medical school in the primary care curriculum. Thank you for being here and for giving us all of this data. It's really helpful to see the trends. What's that?
I was trying to find you.
Oh, I'm here. I'm not used to not being found. I'm very tall. It brings so much clarity when we're able to see all of this data and really see the trends and understand what's going on kind of beneath the layer of, general talk. What I find on a more granular level in my clinic is that it is really, really difficult for me to even start to try to come up with a solution to patient affordability because I have no data. I can't even start to measure anything because I don't know what the costs are going to be to my patients across the various hospitals and insurance plans. And I'm wondering what you think we can do from a data perspective, what we can do with polling to kind of try to get at, how do we show that we can't even start to address this problem because we don't have the data from insurance companies and from hospital plans? Is it polling doctors to say, I have no idea, look at the numbers, none of these doctors know? Or, how do we kind of get that support from the public and providers to really put political pressure?
Such a good question, and it's the big challenge, and the core of the challenge is to be able to give people real information on their out-of-pocket costs, and so they can make more informed choices about what it's actually going to cost them. We don't have the data to do that. There are a few efforts underway. I don't have a magic answer to that. We're all working on that, in different ways.
It's so great to just have a patient affordability tool, but it's really sad we can't even.
We have various tools, but the hardest thing and the thing they want to know is what's it actually going to cost me, and leave aside the quality data that they also want and the other things that go into that equation. But just the cost data is such a challenge. I wish I had the answer to that, but it is the big question.
Great, we actually do have a few more minutes. Do we have any other questions? I have a question. Karen Salvador, Medical School. I wonder if we could end with some words of wisdom, especially for some of our trainees and junior faculty who want to be involved in policy work and are and help them sort of navigate advocacy, policy, politics. Since I think the foundation is a good example of one of those areas, but I won't say which.
I guess I would just say some quick things. First of all, please get involved. We desperately need you in policy. We also need you in government. If you're not feeling like this is a time to be in federal government, state and local government, as I was saying, can be a wonderful place to make a difference. Second, as healthcare professionals, you have, and I want to say this right, you have automatically the potential to have an outsized impact in policy discussions. When you show up in a state legislature or in the Congress, you have a credibility that the rest of us with useless PhDs don't immediately have. But to have that impact, you actually have to engage on the agenda that is the policymaker's agenda, which is often not your agenda. So they're focused on financing, they're focused on Medicare, on Medicaid, on a set of policy questions. You may be focused on more clinical issues or delivery issues. If you really want to have an impact, you have to make the jump to light speed and have engage with them on their agenda. They're only ever going to be so interested in your agenda. And the third thing I would say is, particularly those of you who have an academic bent, is do not limit yourself just to the stuff and the data that is in your publications. Remember that you are an expert on stuff. You may teach, you publish, but by virtue of doing all that, you have mastered a subject area or many subject areas. So play a role as an expert. Do not be afraid to speak out on stuff that you haven't published on, whether that is in a task force or on a commission or and this is really how health policy information is relayed to policymakers, at a cocktail reception. But remember that you can be players in the field and have an impact way beyond what you may ever publish or collect data on, because you're experts on stuff, on subjects that you have mastered. So those are just a few things.